Good afternoon, everyone. I think we'll get started. That's us at past now. I know there's more people joining, so welcome everyone to today's Early Intervention in Psychosis, or EIP, National Network event. This EIP programme is part of the Improvement Hub of Healthcare Improvement Scotland, and this work has been active since about 2018, and as it's a national priority, is currently funded by the Scottish Government. The aim of this work is to develop, design and deliver EIP services across Scotland and improve outcomes for people with first episode psychosis. So as part of our learning system for this programme, we are providing you the opportunity to hear from our speaker, Dr. Sriyidya Iver, who I will introduce in a moment. I'm just going to go over some housekeeping slides for this session first. So this session is being recorded, and the recording and any resources from this session will be made available within a couple of weeks of us from today, and it will be put on the website, which we'll give you a link to. If you could use the Q&A function to submit your questions for the speaker, that would be great. We've got somebody coming in to moderate the questions and facilitate that once Dr. Iver's finished speaking. If we could go into the next slide, please. I think there's a picture showing. Yeah, so there you go. There's where the kind of the speech bubble is for your question. So if you pop that in the box, we can pop it into the main chat and you'll be able to see. You'll also be able to click on your favourite question. So just what you can see being demonstrated here. Once you've popped your question in and it goes live, you can actually like a question, and we'll take the most popular questions out for Dr. Iver to answer when she's finished. So please use that section if you can. And next slide, please. That's just for us. Cover that at the end. So I would like to introduce Dr. Iver, who is a psychologist and an associate professor in the Department of Psychiatry at McGill University. Dr. Iver is an associate member in McGill's School of Population and Global Health and a researcher at the Douglas Research Centre in Montreal, Canada. And her work focuses on youth mental health and early intervention, including serious mental health problems such as psychosis. And she seeks to ensure that more young people have timely access to high quality, youth friendly mental health care and enjoy well-being and social and economic participation. So Dr. Iver partners with youth, families and communities to influence practice and policy in Canada and globally. And she leads on the Access Open Minds, which is a pan-Canadian network of over 250 diverse stakeholders serving the urban, the rural, the Indigenous, post-secondary and homeless youths at 16 sites. She's also been involved in various mental health capacity building and research projects globally, particularly in India, where she was born and obtained her initial training. And Dr. Iver has received numerous awards and was inducted into the Royal Society of Canada's College of New Scholars, Artists and Scientists, and named on the inaugural list of Canadian women leaders in global health. She's also the Vice President of the International Association for Youth Mental Health. So it's quite a CV, and we're absolutely delighted that she can join us today. Just before I pass over to Dr. Iver, once her presentation is finished, we will have our clinical psychology lead, Dr. Susie Clark, who will be managing the questions for Dr. Iver. So without further ado, Dr. Iver, over to you.
Thank you, Ashley, and good afternoon to everyone in Scotland. I wanted to begin first by thanking Dr. Rajiv Krishnadas, Dr. Susie Clark for this invitation, and also this entire team. We've had a few meetings. I think it's probably the best organized webinar I have ever given. So I'm really looking forward to it, and I appreciate the invitation. So I just wanted to begin by, as mentioned by Ashley, I'm joining you today from Montreal, Canada, and I work at McGill University and Douglas, which are on land which has long served as a site of meeting and exchange amongst Indigenous peoples in Canada. And we recognize and respect this history, and more importantly, in all ongoing work, try to honor these continued connections with the past. I have no conflicts of interest to declare, and I have some funding, research funding, that I will be talking about later in the presentation. I thought I'll start with a little bit of a story, because I think a lot of what connects everyone, irrespective of contexts, are stories, and you'll see a little bit of why I do what I do in following along this story. I come from India, in case that's not very clear, either from my looks or my accent. That's where I initially trained as a psychologist. I worked there, including in a large mental asylum or hospital, and also one of India's largest public hospitals, and really felt this need to know better on how to respond to the needs of people with schizophrenia. And this kind of took me to a journey to do my PhD in the United States, where I again ended up working in much better funded, resourced, but still long-term rehabilitation programs where many people spent 1 year to 2 years, people with serious mental illnesses. I learned a lot, but I ended my PhD with this feeling that I really wanted to start where people started their journeys, often with mental illness, so when they were younger. And that kind of brought me to Canada after my PhD, which is where I was first introduced to early intervention for psychosis. And I want to kind of take a little moment here to talk about where in Canada I'm based. I'm in Quebec, which is the only officially Francophone French-speaking part of Canada. And there's sort of an interesting history and parallel between Quebec and Scotland in relation to sort of, we've had referendums, we have and have had a strong sort of separatist movement. And in fact, when Scotland had its referendum, you could see, and I put a little picture here of graffiti that you could see in Quebec, which says Écosse, so a strong sense of solidarity with Scotland. So on that note, so as I mentioned, it was only when I moved to Montreal, Canada, that I was kind of really introduced to this idea of early intervention for psychosis. And I do research. I'm a clinical psychologist by training, and I actually coordinated this program. So I did predominantly clinical and administrative work for the first few years after my PhD. It's a large and one of Canada's well-known early intervention programs in Quebec. And this program is called the Prevention and Early Intervention Program for Psychosis. It's a program that I'm still quite attached to in terms of research. The program was started by Ashok Mala, whose name you may have heard of if you've looked at early intervention for psychosis literature. He's one of the pioneers of early intervention in Canada. It's a publicly funded program. It's a standalone program, but interestingly, it's in a large psychiatric hospital. It serves a specific catchment area for about 400,000 people. We have an age range of 14 to 35 that we cover, both affective and non-affective psychosis. And we also house within this program a sub-program for youth at ultra-high risk for psychosis, and the predominant focus being first episode psychosis. Beyond this, over time, I'm doing more and more programs that are networks of early psychosis programs. So a lot of what I will be presenting to you today is work that involves not just the PEP program, but also other early intervention programs, both in Quebec and in Canada. I won't be talking to you a lot today about some of the work that I've been doing in youth mental health. And the only reason I wanted to mention this is because it is something perhaps that I see as happening in many parts of, at least in many high-income countries, where there is this extension idea of, can we use the same principles of early intervention in terms of early identification, rapid access, appropriate care? Can we use these same principles and extend it to many more, so across the spectrum of youth mental health problems? Because like whether it's eating disorders or personality, there are needs that are quite similar in terms of the need for early outreach and intensive follow-up in the beginning. So this is something that's happening quite a bit in Canada. Like there's been a huge push towards that, and I'm quite involved in that. It's not work that I will be talking about today, but if you do have any questions, I'd be happy to share more details. The only other reason I wanted to mention that is because in sort of conversations I've had with the team in Scotland and thinking about this event, one of the things that struck me a lot is this parallel between some of what seem to be challenges about diversity of context and how that imposes challenges in offering high quality early intervention. And I wanted to briefly mention how within this one youth mental health reform project, we are working with 16 sites across Canada that really span diversity in terms of we have urban, rural, remote, English-speaking, French-speaking sites that serve homeless young people, sites that work primarily with ethnic minorities and refugees. So it's really a wide spectrum of diversity, and certainly it has made me quite familiar with some of these challenges and the need for contextualizing core components of early intervention and youth mental health services transformation. I mean, having spent the first little less than a quarter of my life in India, I certainly have continued contributing to participating in and learning and being inspired from projects that I have the privilege of being involved in, primarily in India, but also in other places like Nigeria and Bangladesh. And these have really taught me some important things. I mean, an initial focus of some of these projects was kind of the curious finding from the World Health Organization studies, although they've been criticized often. The curious finding was that outcomes of treated psychosis tend to be better in low and middle income countries, or at least in the studied low and middle income countries compared to high income countries. And even in future, even when this was reworked in multiple ways by critics, at least the finding stood true in relation to India. And this was kind of one of the things that provoked the study. But since then, it's really resulted in very, very interesting kind of insights that I think have applicability beyond India. And I will be sharing some of this with you as we go along today. So in terms of like having kind of shared with you a little bit this history or of my work and of my journey, I'm going to talk to you a little bit about today. I'll start with a little bit of work from Canada, then work from a study in India and Canada and early intervention, and then open the floor. Although I have the honor of presenting this work, it really is the work of many, many people, like my students, young people and families. I work with many clinicians, an incredible team that supports me in doing a lot of these projects, which require a lot of networks and a lot of stakeholder engagement. And I've also been generously funded by various organizations and funding bodies, particularly the Canadian Institutes of Health Research, for which I'm very grateful. So, I mean, I think we can talk a lot about some of the technical components of early intervention, but I think we would be remiss if we don't start with what is it, at least for me, what was it about early intervention that really resonated? And if I would say what it was, I would say it was primarily the philosophy or the active stance it takes of hope, of rejection of therapeutic nihilism, of optimism, of believing in people's potential and recovery. So this is kind of like at the heart of early intervention. And as we navigate uh, obstacles and challenges and barriers to implementing early intervention as designed, it certainly is super helpful to go back to these values of early intervention. The other thing, keeping in mind also, is that we are often, the majority of people we serve are young, um, in late adolescence, early adulthood. And what that means is that it is an incredible period, not just of transitions and vulnerability to mental ill health, but also a period of incredible potential and important milestones, life milestones. And keeping this at the heart of everything we do is really something that at least has kept me going, this focus on hope and this focus on youth and its potential. So, as you know, every time I do something like this, and I'm often struck by something that's important to remember. In everything, especially in early intervention, we are part of a large movement globally. And there are many, many services. So this is a map that I pulled from the International Early Psychosis Association's website. True, there are large tracts of the world where there isn't that kind of early intervention services, but in many, many high-income countries, you can see that there's been a strong, beginning in the 1980s and 90s, an exponential growth in early intervention services and early intervention services research focused on psychosis. We also have many, many clinical guidance documents, like standards, frameworks for early intervention, including, I know that there is a section on early intervention in the Scottish guidelines for schizophrenia. So we're doing currently a scoping review of clinical guidance documents for early intervention, and we have about 58 to 59 documents. So you can see that. And what's interesting is that there are some core convergences in terms of values, in terms of service organization and interventions that cut across many of these documents. Indeed, there are some points of divergence, but there's a lot of common core values and service standards. And the quality of guidelines varies. And again, sort of an aside, there's a wide variation, and some guidelines don't really score very high on the rating for the critical appraisal of the quality of guidelines. And I wanted to mention that one of the ones that long before I got this invitation that we often looked at as an example of a guideline with great quality with the SIGN guidelines, which scored really high. And what is super important, it scored high on all items, but I thought that one of the areas where many guidelines for early intervention struggle is taking into account the views and preferences of the target population. So only 5 guidelines actually scored high on it, and SIGN was one of them. And what's all beyond these guidelines and involving people with lived experience in these guidelines, what I've noticed is that there's incredible amount of momentum, as I've been reading online, in engaging people with lived experience in the early psychosis service design and evaluation efforts in Scotland. I read that as part of, like evaluating and thinking of the next steps for early intervention, about 130 people with lived experience were consulted. And I certainly know that we've not had that scale of consultations or involvement of people with lived experience in Canada. So I was very, very impressed to see that. In Canada, so early intervention in Canada has a long history. So some of our earliest programs are 97-ish. But one important thing to know about early intervention in Canada is that in Canada, healthcare is provincially and territorially managed. So what that means is that we have massive regional variation in terms of the extent to which there is policy commitment for early intervention, the extent to which there's specific funding, the number of programs, whether or not the province has guidelines to support any training or implementation resources. So they really vary across provinces. Some of the provinces where this is much further ahead are Quebec, Ontario, British Columbia, and Nova Scotia. And you see some of the guidelines here. I won't go into this because I'm fairly sure that many of you are quite familiar, and this is also something that you could possibly pull from Google. And the point over here is that there's an incredible amount of evidence, albeit with critiques, for early intervention, particularly compared to regular or traditional care. And the last sort of the meta-analysis on this was done by Correll et al. In 2018, where they had 10 RCTs, and on 13 outcomes, they found that early intervention was associated with better outcomes. I wanted to make a point here that the size of these reflects kind of the size of the effect. So for instance, involvement in school or work, the impact is a lot more than negative symptoms. So the size of this is kind of a little bit illustrative of the impact of early intervention on those particular outcomes. So you can see that on a range of outcomes, early intervention has been associated with better results than treatment as usual. It is, however, important to note two things about this evidence. One, that most of it, almost all of it, comes from high-income countries. And the second, that most of these trials are of standalone early intervention services. So these are two limitations, at least in the trial evidence for early intervention, that must be acknowledged. There's also been an incredible amount of work done that goes beyond trials to really document what is the state of implementation. To what extent do early intervention services follow the guidelines? To what extent are they able to deliver interventions as per the standards? What are the barriers to this? What are the facilitators? Is there improvement over time in a region as they start implementing early intervention services? Is there decay? So there's been numerous such efforts in Canada as well, and in Quebec have been quite involved in this endeavor. And here are some of the papers, and some of the findings are that overall, that there are certainly many components on which across the board, whether we are talking about Ontario or Canada, different programs in Canada or programs in Quebec, that we do seem to be able to implement some key components of early intervention well. So for instance, offering rapid access to an initial evaluation is one example, or offering access to a psychiatrist. But then there are some areas where there is inconsistency, and I'll talk to you a little bit about that, and certainly some challenges that are imposed by context. One thing that I did want to talk to you about is a very interesting thing that we found in our last implementation analysis in Quebec, which was in Quebec. We had our first early intervention program started in 1997, but we did not have policy level investment or support for early intervention in Quebec till 2017. Okay, so it was primarily started by some champions who really believed in early intervention and started a service. There were no standards or guidelines. There was no separate funding envelope for early intervention, none of that till 2017. So at that point, we had maybe, like a few programs, 15 to 16 programs in different parts of Quebec. And in 2017, after a lot of advocacy, we now had additional funding. We had, for new programs, we had specific funding for early intervention, separately sort of kept for EI for psychosis, some implementation support, and our first published guidelines for early intervention. So it's a very, very interesting history. And what we noticed was that when we had done implementation surveys before, and when we did it after, a few years after this sort of provincial policy change, we found an incredible increase in programs' ability to adhere to components. We also had a huge increase in the number of programs, the number of people being served, suggesting that that kind of policy level support and investment, both in terms of funding, but also implementation, can really support programs in very diverse contexts to be able to deliver quality early intervention. Now, across these implementation studies, and if you look at studies from elsewhere in the world, the UK, Australia, there are some challenges. So we do have challenges in terms of evidence practice gaps, being able to offer evidence-based interventions. And we also have challenges in terms of implementing services consistently according to standards. So there might be some programs might be able to adhere to some standards more than others. There might be variation across programs and within a program, depending on the standard that we talk about. And there are some common challenges as well that many regions and jurisdictions have with respect to geographic challenges, equity, engagement. Although it's much better than traditional care, we still do have anywhere from 13 to 27, 30% of young people disengaging from services before completing the 2 to 3 year program of care. The involvement of persons with lived experience and their families. So these are some common challenges. So across the board, like I said, there is an evidence practice or a standards practice gap. The other sort of challenge, what I really like this paper because it talks about, talks about the challenge of delivering something that was first conceived in an urban context as a standalone service. How do you implement something like that in rural and remote contexts? So this paper calls it the Gordian knot of early intervention. It's a really nice paper from 2013. And preparing for this, I actually reached out to Dr. Cheng to get some sort of insights. So some of these, what I will share with you, are also some insights from having spoken to her because she has years of experience delivering early intervention in rural and remote Northern Ontario. So the next little while, I'm going to try and talk to you about these two challenges, the evidence practice and the remote, with some examples and insights on how we've navigated some of this in the Canadian context. And I'd be really curious to hear your thoughts on whether some of this resonates with your own experiences in Scotland. So the first thing that I will talk to you about is this project that I am co-leading with a number of other close colleagues and friends, including Dr. Amal Abdelbaki, Dr. Marc-André Roy, and Dr. Manuela Ferrari, and others. It's a learning health system to support early intervention for psychosis services in Quebec, Canada. Of the numerous research projects that over the years I've participated in, it is one of the ones that I think I'm most excited about, most proud of, and most eager to share when I do presentations. So that's maybe in terms of learning health system, like it's if you want to kind of really put it very simply, the idea behind the learning health system is that we want to create virtuous real-time feedback loops between data, practice, and knowledge. So the idea is that we collect data from service users, from families, from programs, meaningful data that they think has an impact and can be changed. So it really has to be meaningful data. You provide real-time feedback and use that feedback in real time to both improve treatment decision making, but also service improvement or service design. And then you measure again, and so on and so forth. So really creating virtuous iterative cycles from knowledge to practice, practice to data, and data to knowledge. Now, on the one hand, it sounds very intuitive, but anyone who's tried to do this sort of work knows that it's quite a task to be able to really do this well and in a manner that engages all stakeholders. So in this project, it was initially funded by a research grant and since then has been supported for sustainability by the ministry in Quebec because it's really been, there's a great uptake of the program. We had 11 programs out of 33, so 11 early intervention programs in Quebec in the beginning that participated, and we really tried to take a variety of programs, so urban, rural, those attached to academic sites, those that had nothing to do with academic sites, those that had been operating for many years, and those that started after 2017 when the government first invested. So we really tried to get a diversity of sites participating in this project. An important element of a learning health system, the data is actually one part of it. It's really the culture of creating a community that learns together. And for this, it's really important that all stakeholder groups, service users, family members, clinicians, team managers, administrators, researchers, and decision makers are working together. So from every step of the project, all these stakeholders have been involved. So right from choosing what indicators or standards we should assess, what makes sense, what can change, what would you be interested in knowing about? How do we do that? What kind of technology, how should it look? How easy should it be to use? And the heart of early intervention of a learning health system is really not data collection and technology, but creating a network that gets feedback about these indicators and standards and has a sense of learning together to improve. So the capacity building and feedback was also shaped by stakeholders. And then going back to learning how this improves outcomes, transforms practices, and so on and so forth. So these were some of the indicators we chose, and I won't go through the detail. And as you will tell that some of the indicators are about the period before young people walk into an early intervention for psychosis. Some are during and some pertain to the transition or discharge process. And it's by no means an exhaustive list. We really started with a small list that stakeholders thought was really important to start collecting data on, to learn about, and to improve. So this is sort of really important that it's a consensus list of indicators. These were some of the technologies used. So clinical team leaders filled out data every 4 months. And throughout, this is a living project. So we've changed the frequency based on feedback we got. We collected data, like, if you've gone to the airport and clicked one of those buttons about how satisfied you are, this is something service users wanted, and we integrated that into the setup. So really easy, quick ways to assess data, but from all stakeholders. And the most important thing was really meaningfully designing feedback. So the feedback was about how a program is doing over time. It also compares the program with what the standards say in Quebec. So it also compares the program with other programs. So what's the mean, the highest performing program, the program that's struggling the most with the standard, and it provides tailored recommendations on how, so a little bit about rationale for why is the standard so important, and what are some ways to, if you want to improve, how can you, if you want to maintain, how can you? And I'll give you an example. So here on the left, is an example of the feedback that we give for access delays. And what you can see over here is the blue is the standard. This is the program that has the maximum delay. This green is the clinic that is getting the feedback. This is the program with the least amount of delay. And here's a little bit of rationale for why it's important to try and reduce delays and simplify pathways to care. Here's another type of feedback on the right, which is really about whether or not programs are following some core simple practices with respect to ensuring a smooth transition from early intervention to other services at the end of 2 to 3 years. So whether or not there was a transfer plan, whether there was contact after the patient was transferred, things like this. And again, you can see the number of clinics that are doing it and where you are in relation to that core component or practice. The capacity building took various forms, from like tools to knowledge exchange. We also had mentoring of programs, pairing programs. So for example, pairing a rural program with another rural program that had navigated a challenge. So we had a variety of things that we did to support programs to improve their capacity and to improve the quality of clinical practices. This study, I mean, we took a bit more of an implementation science lens, looking at things like reach, effectiveness, adoption, implementation, and maintenance. And I won't really get into the details of this. We're in the process of analyzing and writing it up. But the main sort of things in terms of insights so far, I think one, that a learning health system can promote evidence-based care in EI services. One of the first things that changed was in the beginning, very few programs even had any data that they could share for these basic set of indicators that they had chosen. And as we went along, more and more programs were able to feed in data into the learning health system, and programs were actually telling us, like, for us, it'll be important to know, add this one bit because we want to know whether the bottleneck is there or whether this is the problem. So it was really interesting. This is perhaps one of the few research projects where we had clinicians and patients and families sharing what more data to collect. It was kind of really an interesting experience to say that if something is meaningful and meaningfully engages stakeholders, you can also promote a lot more involvement of stakeholders. The second thing that we noticed was that things that we targeted with tailored capacity building, there was improvement in being able to align closer and closer to standards. The third and most important thing, perhaps, is that doing something like this not only improves the quality of services, but it creates a sense of belonging to a community that aims to learn and improve. So it creates a culture of belonging and a culture that's committing to together improving quality. And I think that that common thread is very, very important. Of course, we have some challenges with respect to better integration of technology, what works, what doesn't, but it is a promising approach. What next with respect to this project? We are now thinking about how we can support programs beyond Quebec. We're thinking about a pan-Canadian sort of scale up. As part of that, we are creating resources. So on this website, you will find some resources with respect to measurement-based care, learning health systems. I'm happy to share the slides with you all later. And as I said, like I also realized from reading some of the work in Scotland, the reports from Scotland, this is something that you are also thinking about, what indicators or what metrics. And we certainly have some process insights about how important it is to take into account feedback from multiple stakeholder groups in designing this sort of pan-Canadian learning health system. So we just finished a Delphi study in this regard. And the other most important thing is to not start with whether we should use this scale or that scale. It's much more important to have consensus on what are the values, aims, and outcomes that are even worth measuring. I think that that's where the consensus bit is critical to get. So moving on to this next bit that I told you that about this remoteness and rurality and sparse populations, spread out populations. And what you can see here is a map of Canada on the left and Scotland. And I mean, clearly, like in Scotland too, the majority of like a lot of areas are rural, even though the percent of the population living in these rural areas is less, and that's the same in Canada. And you can see in Canada, most areas are light green, orange, or red, which is that they are less accessible, remote, or very remote. And in terms of population density, it's also very interesting. I was looking it up in preparing for this presentation, and I think there's like a huge, I think in Scotland it's about 80, and we have a population density of 7. So it's all, but the common element being that in one way or the other, we're struggling with similar challenges with respect to remoteness and rurality and the need to adapt early intervention to these diverse contexts. And I think there is no debate about whether or not providing high quality care early in the course of illness, irrespective of where people live, makes sense. So this was a quote that I pulled out from your report on the vision to improve early intervention in psychosis in Scotland. But there is also a common acknowledgement that there are numerous challenges that we need to take into account when we are delivering services in sparsely populated remote and rural areas, and that taking standalone EI services and implementing them in rural remote contexts is not always feasible, that we may need to tweak, we may need different approaches. The unfortunate bit is that we don't have a lot of evidence, despite the fact that there are reports from Australia, from Canada, from Scotland, from UK, and from other parts of the world that there is a sense from the ground that people are struggling with this and responding to it, but there isn't a lot of evidence. In fact, there was a review published in 2020, a systematic review of how early intervention for psychosis has been adapted for rural contexts, and there were only 5 studies that they found. So really and the point over there being that different models seem to have positive impacts. We don't have like a clear direction, but it looks promising. Adaptations are possible, but it's sometimes hard to adhere to all essential components of early intervention in rural and remote contexts. In general, in EI, one of the things that I think needs to change a little bit more is that we don't have that many studies comparing different models. So for example, comparing generic care with enhanced generic or early intervention care, and in different contexts. So hopefully this is sort of the next set of what we end up doing in EI that will really have a lot of practical implications for improving services. So in terms of models in Canada and Quebec, and you will see very quickly how this will be very similar to what I saw in some of the reports from Scotland. So we have a number of programs, predominantly in urban contexts, that are standalone. And in the rural context, we actually have 2 types. We have the hub and spoke models, but we also have enhanced community mental health teams. Now, with the hub and spoke, what's interesting is that this was kind of the first version of it was in Ontario, and we certainly have hub and spoke, but over time, there have been many, many challenges as well with the hub and spoke model, with this idea of one hub and there being many spokes in more remote or rural areas. There have been many challenges, including in this perception that this idea of a hub can be seen as top-down or hierarchical, and I'll talk to you a little bit more about that in the next slide. And some of the variations have veered towards this idea of a network model, which feels a little bit more equitable. Also, this idea of not just a hub, but it's not the hub that reaches out to the spokes, whether it's by telemedicine or traveling or by really being available to general practitioners and other mental health workers in the spokes. So really some variation on this idea of the original version of the hub and spoke. We also do have enhanced community mental health teams. So teams that offer other services. It could be youth mental health services or services for people with multiple episode schizophrenia or psychosis, and some people within that team being trained specifically to deliver early intervention. And within that, a variation we have, and certainly something that the US did in a very grand form with the RACE study, which we are now also trying out in Ontario, is doing this enhanced community mental health teams, but in a manualized way. So for instance, using some clear standard manual. So it's a lot easier. We'll see, we don't have the results yet to implement. So these are some of the ways we have been responding to this challenge of remote and rural contexts, and some really like more like insights that you won't find perhaps in papers or like very easily. So in Quebec, for instance, we found that whenever you have an enhanced community mental health team model in a rural context, you really need the manager to be trained in early intervention. And you need, even in the smallest site, at least 2 staff members, so that if one goes on vacation or one is not available, that we have a clear plan and that they have some peer mentoring and peer consultation. It's important that the team members are connected to this larger community of practice so they don't feel isolated. And we found that wherever the enhanced teams have many psychiatrists, it seems to work a little less well compared to having 1 or 2 psychiatrists who are spending a bit more time, even if they don't do EI exclusively, but they're spending a bit more time on EI. We've also had some incredible sort of successes in delivering specialized interventions online to multiple clinics, particularly after COVID, some of which are not really covered by state finances, but through academic partnerships, some through the state. So we have cognitive behavior therapy, cognitive remediation, peer facilitated like physical health interventions, family peer support being delivered through this sort of model across sites in Quebec participate. The other important lesson we've learned is that whatever form this hub and hub personnel or the key champions who are promoting EI take, they really need credibility. And what I mean by credibility is this isn't in terms of guidelines or standards. This is about being available. This is about being passionate. This is about going a little extra mile, because it's not, otherwise it just doesn't work. Like that credibility and availability bit is very critical. Being available to a nurse practitioner, being available to a general practitioner, being willing to also drive to the spoke. That sort of credibility is offering training, offering extra support. These sorts of things, these relationship elements go a lot further. And even in qualitative work, they seem to be the critical elements to make some of this work. Funding needs to be creatively thought of. So you need travel for families and funding for that. The governance piece, which we often neglect, and you find hardly anything about that even in the guidelines, is really critical. Like, what kind of governance model works well? How can we create a governance model where we have all stakeholders, but also this regional diversity with some equity represented? Really important to involve multiple stakeholder groups and sectors, particularly in rural and remote contexts where sometimes they can play a bigger role, and sometimes it's important to do so, like teachers, police officers, like really mapping out who are these stakeholders and sectors that need to be involved. And if there's like one thing that I would highlight from both the literature, but also speaking to multiple people in thinking about this presentation, is the importance of community and champions. Like really the sense of a network, of an association, being part of a larger group is super, super important. Bringing together lived, loved, and learned expertise. And then also not always seeing this as a barrier or as a challenge. But one of the things that through the Access project that I've learned is that in contextualizing early intervention to diverse populations and diverse contexts, there can be a tremendous potential for creativity, for leveraging local strengths, for tailoring to specific populations. So in a lot of the work in Access that we did with Indigenous communities, we learned a lot about, culturally grounded interventions, like thinking about, people in the community playing a role in promoting recovery, things that I would not have thought of or learned had I not embarked on this journey. So it's not only about thinking about resource constraints, but also thinking about what opportunities they present. I'm going to go a little quickly to make sure that we have time. This last bit, there's a lot from this work, but I just wanted to highlight a few key points from some of the work that I've been doing in partnership with colleagues at the Schizophrenia Research Foundation in Chennai, India, because I think that they have a lot of salience for us in high-income contexts, thinking about how to implement early intervention. So as we know, my graduate student Ruben Valle is actually currently trying to do a systematic review on the extent to which EI or multi-component interventions are available for people with psychosis in low and middle income countries. And we find that there's hardly anything out there. One of the things for the last 10, 12 years, I've been collaborating with the SCARF program in Chennai. And as part of NIH funding from the US, clearly it's a global world, like getting funding from a US body to do work in Canada and India. And we set up this early intervention program with research capacity that has common components like case management, psychopharmacological management, open referral, rapid access. But it also has some unique aspects. It's a non-catchment area, like things are just not set up that way in India to have geographic catchments, which means you have to really think very creatively about how you would deliver services to people who might live very far from the clinic. So thinking also about adaptations to the local context. So this has been, but it has been possible. And as you will see, it's also quite inspiring. One of the things that we found in having set up these two programs and then having followed a cohort of 165 young people at approximately 165, 168 in Montreal. So in our early intervention service for psychosis in Montreal and in our early intervention service for psychosis in Chennai. We followed them and we had both quantitative and qualitative data and different types of data looking at different outcomes and different variables. We found that clinical outcomes, particularly negative symptom remission, was much better in Chennai compared to Canada, and some of the factors that facilitated it was early remission and family support. So we keep coming back to this variable of family support or family involvement. However, we did have 4 people who died in Chennai, none in Montreal, suggesting that we may need to think about mortality outcomes in low resource contexts a little bit more carefully. We also found, and I think to me, this is the most striking finding, all patients and families in Chennai were in contact with the treating team for the entire 2 years. Like nobody dropped out. Okay. 31 patients dropped out of treatment before month 24 in Montreal. And what was also interesting is that family contact predicted service engagement of patients in Montreal. And in Montreal and in Chennai, family involvement is high, which is what you would expect with early intervention. But what's different is that over time, it goes down in Montreal, but it stays consistently high in Chennai. The other important thing, which I think is great sort of inspiration for us, is that a lot of the contact in Chennai was also through phone, through remote means rather than in person. So it's possible to have high levels of service engagement, not necessarily always in person. We also found that many more people with their doctors tapered or went off meds in Chennai compared to Montreal, but did not necessarily have worse clinical outcomes. Now, this needs to be tested a bit more in larger samples, but at least it points out to the question that can gains be maintained with low intensity follow-up, particularly if certain facilitating conditions are there, like family involvement. And I know that there are a number of such trials going on, but unfortunately, almost all of these trials are in high income countries. I mean, and you could ask a number of questions about why is it that family involvement is much higher in India. And there are many, many reasons for that. Our values systems might be different about the role of family, the role of the self, treatment structures and processes. Who's the unit of therapeutic attention? In high income countries, it's often the patient. How do these different stakeholders see their role? So what you see here is a simple tool that we used in this project. It takes like a minute, no language, and people are asked to just divide this pie the way they think, how much responsibility they want to attribute to the family vis-a-vis the treatment team, vis-a-vis the patient. And what we found was that consistently in Canada, the patient was given the most amount of responsibility, versus in Chennai, it was first families and then an equal amount of responsibility was ascribed to treatment teams and patients, suggesting that some of these stakeholder role perceptions might play a much bigger role than we've perhaps given them credit. This last sort of innovation from Chennai, one of the things that I think in EI we haven't thought a lot about is mobile or traveling clinics. So this is a model that was used by the same not-for-profit organization. It's a bus that goes across rural Tamil Nadu, primarily staffed by lay workers or community workers, so not specialists, so not your psychologists or psychiatrists. They go across. If they need to meet a specialist, it's through telepsychiatry with a screen inside this mobile van. The same mobile van also has a pharmacy. And at night, if you know anything about India, the one thing that unites India is love for movies. And so at night, movies are used to promote education about psychosis, about mental illnesses. So it's really like one more avenue for innovation, I think, that we may have underexploited thus far. There are a couple of examples of this sort of traveling clinic or mobile EI from high income countries. So I've listed them here. One is in Ontario, and the other is an interesting study which needs a little bit more evaluation, but from Greece, where they had one EI hub, and then they had a mobile generic mental health unit that traveled across distances. So if you're interested, these might be ways to look at examples both from a low resource context, but also from high income countries. So some concluding thoughts, and I'm really curious to hear more from you. I mean, overall, I think that locally and globally, there's a lot to be gained by creating these sorts of links between research and evaluation and services. So you innovate, and so that research doesn't happen somewhere else or data doesn't happen somewhere else, but really bringing all stakeholders together, thinking about what makes sense to collect. So really evidence generating services, not just evidence-based services, and creating this sort of a learning network or learning health system can be super critical for early intervention to foster, to maintain gains, to be able to resolve and navigate challenges together, and to have the sense of community. The other important thing I think in this next frontier for early intervention is to really think hard about how can we take core principles of early intervention and contextually adapt them. So so improving outcomes and services may require this sort of context sensitive, but high quality application of core principles. And unfortunately, we don't have a lot of evidence or guidance for this. So we may want to be part of the people who actually create some of this evidence. So we need more practice-based and practice-led research. And this is an invitation, perhaps. I think in Scotland, I see a lot of the work in the last few years that you've been really embarking on and being very inspiring. And I think that there could be a lot of practice-based insights and practice-based research, and that can be very, very useful from Scotland with respect to thinking about these sorts of, user involvement, remote and rural contexts. The last thing I would say is that everything need not be super complicated. Sometimes simple technology. So one of the things we found in our study from India was that one of the strongest predictors of whether or not people stayed was whether or not every month there was some contact between the treatment team and the family member. So very simple. Can we create some way to ensure that there's monthly contact, even if it's by phone, between the family members and the treatment team? So sometimes simple things can be quite powerful. And then the last thing, I didn't do a lot of justice to it today, but I did want to make a point about the fact that whatever we are doing, we are embedded in larger societal forces and mega trends, we and the people we serve, and to always remember that we may be talking about early intervention, rapid access, delays, psychosis, and all of these sorts of things, but there's a lot more that's happening in the larger world that is shaping actively both service providers, but more importantly, the young people and the families we serve. Thank you. And with that, I'm going to stop sharing so that we can have some room for discussion. Susie, you're muted.
Thank you so much. That was absolutely fascinating and just really, it was so validating, because I feel like you've got a real kind of strategic perspective of EI in all these different contexts and all these different continents, which is really helpful to hear from our point of view, because we can be a little bit like a goldfish bowl in Scotland, just looking at the very few other EI practitioners and people who are trying to support this. And I think the truth is that we've been on a bit of a journey for the last 20 years. Esteem in Glasgow was a pilot study 20 years ago, and we're still chipping away at trying to get EI services developed across Scotland. But I do think what you have highlighted is really, really valuable. I think that one size doesn't fit all, and what suits inner city Glasgow with its urban population is not going to be what is needed in the Highlands. And I'm much more kind of aware of that now, I think, having understood the complexity of local contexts. But I think one of the barriers we have is that sometimes when you first present the idea of EI, people will say, well, we do all that anyway. And having worked in CMHTs and crisis teams and all the rest of it, that's not necessarily what happens. There is something unique about the integrated nature of the team in EI, about the developmental stage of the client group, about the family involvement, and about the kind of optimistic message. Hope and recovery is possible, and the social and vocational recovery, not just the symptomatic recovery. And I think that is what's key to EI, and it's how do you move those core components and enable these core components to be delivered in these different areas. And I think there are some lovely examples of hub and spoke models in England that we've been able to learn from, which is great. And they've definitely had, lots to say about things like having the base hub where there are the sort of senior experienced clinicians that can do supervision and can help with complex cases, but having local, well thought of, credible staff,
absolutely essential,
linked in with the community. And that combination is needed, but you need the funding to the hub to then fund those staff so that they don't get pulled in, because otherwise they just get pulled into CMHT duties and they get pulled into desk duty.
Absolutely.
They need to be ring fenced, because we know that EI takes time, the length of time it takes to see families, for example, in addition to the clinical context. So it was really interesting hearing all of that. But also what I loved was, I might want to copy some of your fabulous catchphrases. I've highlighted them: lived, loved and learned experience. I thought that was brilliant. There was another couple that I really liked. And I think we can really learn from Canada because of the remoteness of your population, because
absolutely.
Again, we've had in Scotland, oh, you can't possibly do EI in the Highlands, it's too rural. And I'm saying, well, yes and no. I mean, we know that EI works in Canada in far more remote areas. We know that EI works in Western Australia in far more remote areas. So yes, we can. But I think one of the blessings of the pandemic has been that we've all learned to use technology.
Absolutely.
The potential for things like supervision to be done remotely is much greater. So a nurse on their own in Argyll can link in with our family supervision, etc., etc. So I think there's lots of opportunities as you highlight. There was a couple of questions that came out. If I could just
absolutely,
if I could just raise them. One of them was in relation to involving people with lived experience in terms of kind of their leadership, and I know you did make reference to that as a stakeholder group, but I just wondered if you had anything else you could say in relation to lived experience, advice and expertise.
Absolutely. I think that if there is a critical element in addition to this idea of a community, I think the involvement of persons with lived experience and families with lived experience in all ways in their own care, so that there's shared decision making, but also in service design, service planning, and in projects that are like this Learning Health System project about improving the quality of services is essential. And if there is no one formula for, I think that this is a process of learning and humility, and also of acknowledging different types of knowledge and expertise. And this is also this, so acknowledging, like I said, lived, like loved and learned knowledge. And it's also something that I think when it comes to the hub and spoke, one of the things that I think increasingly we're realizing, while the people at the hub might have learned knowledge about, and also like clinical knowledge, there is important knowledge in various levels of practitioners in rural and remote contexts about what it is to practice in their context. And I think it's really important to find ways to set that equity, because often there can be this perception that, they know about EI and they're coming in without really acknowledging what are the strengths or what are the considerations or what have we learned from years of experience practicing in rural and remote contexts. And I think that finding ways to set that tone correctly, whether it comes to the involvement of lived experience or of stakeholders from rural and remote contexts, is super critical.
That's interesting. And actually, when we visited the islands, one of the things we found was that in the island boards, they were meeting more of the core components of EI without even trying, because they all know each other, and because the addiction nurse was sitting beside the social worker, and the families pop in because they know where the mental health team is based. Whereas in a city like Edinburgh, that just wouldn't happen, because there isn't an EI service, and there isn't people that could. So I think there's lots of lessons from recognising the expertise of the local people and service users and families and community networks that are there. So that's really helpful. The next question is in relation to the at-risk mental state service and how that's provided within the EI service that you mentioned. What kind of support do they get?
So, I mean, I think on that front, and I think our experience, I would say, parallels a little bit the experience of the early intervention for psychosis field as a whole. One of the things that certainly we've learned is that, when the young people who are coming in, who either are coming in because they have a family history of psychosis and have had some sort of decline in either academic or social functioning, or are experiencing symptoms of psychosis, but at a subthreshold level or for a shorter duration. So those are the typical criteria. But what we've realized over time is that, unfortunately, on the one hand, fortunately, very few people actually, quote unquote, convert to psychosis, but they have a high level of needs for follow-up, for family interventions, for support to maintain work and school retention. And one of the things that in Quebec, at least, that we're really thinking about, and in our last guideline, we did change the guidelines about providing some sort of questioning about whether these young people are best served in an FEP service or an enhanced youth mental health service, because many of these young people also have, the ones who are at high risk seem to have needs for school and work supports, emotion regulation, and might benefit from some of the services that are for anxiety, depression, personality. So we're not in the last version of the Quebec guidelines, certainly we've put some questioning about where best. So for now, we're not changing it. We still have the high risk, but we are creating a strong link between that and the youth mental health reform that's also happening in our province and also elsewhere in Canada, to see where best these young people might be served, both with respect to their needs, but also to reduce potentially stigma associated with being followed in a service that can be seen as at risk for developing psychosis.
Yeah, that makes a lot of sense, I think, because in the early stages of psychosis, it's often not obvious whether the person has a primary mood problem, whether it's about paranoia, whether it's about emotional dysregulation and trauma and so on. It's really hard to tease it apart sometimes, even me and my 20-odd years experience. So I can totally see that young people with at-risk mental state need access to all of those interventions. Thank you. The next question is in relation to the transition on from specialist EI services.
Yes.
So really about how many people are going on to CMHT. Are they successful transitions? I think there's a concern that in some bits of England, quite a lot of people with psychosis or who've been through EI get discharged to the GP and then don't get followed up by CMHTs. And so it would be interesting to hear about your experience of those transitions.
So maybe a couple of answers in response to that. I think the more we are talking, the more I realize how much there are parallels in experiences across countries with respect to EI. So we also are struggling with respect to transfers and transitions. So in part because not all programs, the specialized programs, for example, if somebody still needs a high intensity of follow-up, they're not all set up in a way. So for instance, one level of community mental health teams in Quebec, the way it operates is that for the psychiatric care, you need to go to the hospital, but for the case management, you need to go to the primary care clinic. And then that means that the psychiatrist and the primary care clinic might not be coordinating or communicating. And so much of what EI is about is also about that strong link and coordination between team members. There are wait lists, so often we're still following people well beyond the mark because it's very difficult, and we want to make sure that there is a proper transition plan. So we've struggled with that. We have a small number that goes to different level of psychiatric services, another group that does GP, but with some level of psychosocial follow-up. We've done a little bit with our learning health system project to create a standard protocol for transfers and to monitor that, because what we find none of the programs were doing well was doing any handover or really following people after the transition, following them in 3 months or so to make sure. And I know programs are quite afraid to do that because they are afraid that the transfer hasn't gone well, but we are trying to do that in a more systematic manner. It is a struggle, and with the pandemic, we've had such workforce shortages, both in EI and outside EI, that have further compounded and exacerbated some of these transition challenges. But I agree that I think there's actually a very a paper that just came out this week, I think, about this very topic about what's happening with transfers in EI and kind of holding a mirror to the EI world on that. So I think it's a challenge here, just as it is in England and Scotland.
Yeah, no, that's really interesting. I think we've got, certainly in Glasgow, we've got transfer of care document, and in the olden days, in the pre-pandemic days, we would have a face-to-face handover and the nurses would go out together. That's just not the way it's working now. And actually, I've given an example on email. We have patients on CTOs and medication, and CMHTs don't want to take them on because they're so busy or they can't allocate them for a year.
Absolutely.
So the problem is that the EI service ends up holding people for longer. What we did find, though, is that when we were a 3-year service, we could discharge more people to GP because we had longer to deliver the interventions and the family work and have a proper trial of medication. People had their full year of their medication and then had a proper titration down. They had a relapse prevention plan in place. And the problem when you're a 2-year service is you don't always have long enough to do that. So actually it means that more people go to the CMHT. So in terms of investment in the future for Scotland, you know, the guidelines are clear. It should be a 3-year service, because part of what you want to do is reduce demand in CMHTs.
I would agree with that.
And therefore you need to have people for longer.
Yeah. And two other quick bits that I wanted to say is that with our guidelines, we've also said that if someone's younger than 18 when they come in, that we don't follow the 2 or 3 year mark, that we follow them for longer, in part because we really feel that it's already, people find it hard to transition from the child and adolescent to adult, and we don't want that to be compounded by also a transfer from specialist EI to non-EI. We did do a trial here looking at 5 years of extending early intervention, a randomized control trial, and comparing that with 2 years of EI followed by 3 years of regular care, and did find not all outcomes, but some outcomes, clinical outcomes were better when you extend. Engagement was a critical outcome that was much, much better in extended EI. Like, so lots more people dropped out in the regular care arm. So I think that engagement gain, I think, is also something that may be very, very hard when people transfer, because there's so much emphasis on that philosophy of engagement and flexibility so that you can make sure that you can engage people. And that may not be a philosophy that's shared or feasible for other teams.
No, well, it's kind of, I always think of EI as an attachment model of care, really, that at the beginning it's a safe haven. And then part of the service role is to be a secure base and allow people to go and experiment and try things and try time off medicine and go back to uni and all of that. And the service catches them if they can't do that. And the problem, I think, is that's quite hard to scale up into CMHTs when they've got all these other pressing demands. So the next, there's a question about which approach do you think has the best outcomes, family versus patient? Which is an interesting question, because really with EI, you would do both, wouldn't you? You wouldn't have one or the other.
So, I mean, and I agree. I think it's not an either or. Perhaps what I would suggest, however, is that, and this isn't just an EI thing, I think that there is a history in Western psychiatry where we've had different waves of the ways in which we see the role of the family. So for instance, certainly in schizophrenia, like long ago, there was this whole sort of idea of like the role of the family in contributing both causing but also maintaining relapses in schizophrenia. And I think some of that may have shaped the ways in which we involve or not involve families. We've shifted a lot from that to seeing families as partners, but still struggle a little bit in consistently maintaining family involvement. So it's not an either or, but it is in being a bit more intentional about engaging families, because if there is, of all the interventions, like it's so much easier, for instance, for many of us to promote and sell and advocate and push for certain interventions, like maybe in like cognitive behavior therapy, and this is not against one or the other, but the level of evidence is so high for family involvement, family interventions, like it's among the best, but we don't have good implementation of that. So, and part of that, I think, is not about training people in family therapy. It's a little bit of reflection on how we see the role of the family so how do we see, whether we always see the unit of our attention as being the patient or the patient embedded in the system. And when I say family, acknowledging the various types of networks and families and friends that people have, but really pushing ourselves to not see us as primarily working with individuals, but as individuals embedded in systems. And I think although EI guidelines emphasize it consistently, we find that after the beginning, there seems to be a little bit of waning in terms of the engagement and involvement of families. So like it's not either or, it would be to kind of be mindful of the role of the family. And even if you can't offer really complicated interventions, like two strong things that I would suggest, the simplest things in terms of family involvement would be maintaining contact throughout the 2 years. And the second being family psychoeducation. So if you can't offer like systemic or multiple family, like these are the two safe best bets, I would say.
I would agree with you completely. And interestingly, people don't realise that the evidence base for family intervention is as powerful as medication. Every patient with psychosis just about will be offered medication. And in Scotland, I have to say very few of them are offered family intervention.
Absolutely.
And yet the evidence base is the same. It's just, so that's very helpful. Thank you. Next question is from Hamish. How would you recommend we go about identifying and working with core stakeholders? Did you find that you had to summarise key documents? There's high level of interest in the new services in Scotland, but not everybody's got capacity to attend meetings all the time, etc.
Yeah, I do think that overall, and this is not just from the EI work, but also from a lot of the youth mental health work in diverse contexts and the global work, stakeholder engagement is something that takes a lot of time and energy and investment. And it also requires different strokes for different folk. Like, for some it'll be meetings, for some it'll be emails, and to always keep the invitation open, have incredible amount of flexibility. So if you want a meeting with people with lived experience and do it during regular work hours, it's not going to work. Like if you want, you might have to offer evening hours or weekend hours. So really continuously evaluating your approach to stakeholder engagement. Again, creating that learning piece, what's working well, what's not working well, what different approaches might work. Also thinking about different ways. I think we now have, using infographics, like podcasts, like social media, like really thinking about a variety of means and being open to continuously being challenged. Because I think that is one thing that it does require a lot of humility and in making mistakes and acknowledging that this is working or not working. And I would go beyond, like, to really, in rural and remote contexts, being guided by local champions on who are the key stakeholders, instead of going with a priori assumptions about who are the people that need to be engaged, and being open to engaging everyone from like the local, like police, to the priest, to really being open to mapping who the stakeholders are that need to be at the table in each context. And I'm sorry, there's no one easy answer for it, but it is an essential element, even if people don't have time, to try and find ways to make it feasible for people to be involved.
Thank you, that's very helpful. And it does, I would agree that the value of the lived experience, we've got a lived experience reference group nationally and also in the local areas, and it's really important. There's such a powerful lobby and
absolutely
mirror for us sometimes.
Yes.
So it's very helpful. Thank you. So we've got another question about lots of students from abroad and it being more difficult to get family involvement, or maybe cultural beliefs that's like not accepting mental illness or psychosis, or kind of Western framework for things. And we wondered if you had any suggestions to get around that.
So a couple of things, like one, I have lived experience of having been an international student myself. So it's a population that I feel very, very kind of strongly about. There's a paper that I had written a few years ago about international students in early intervention services for psychosis that I would be able to share perhaps with the group. And you're absolutely right. The person who framed the question in terms of identifying some of these key challenges, and in addition, sometimes insurance and financial considerations, visa considerations, lack of family or social support. But I do think some of the things that work in general, whether it's international students or others, is kind of framing these as having multiple illness narratives or frameworks for explaining the illness, and being curious and open to having these different formulations. Because beyond international students, I'm very, very sure that in the societies we live, many people have many formulations that maybe they're not hesitating to share about. And in fact, we've been corrected a few times over history about the role of urbanicity or immigration, and so we could do with a little bit of like being open and curious to multiple formulations about psychosis. Having cultural brokers, so connecting with community or organizations that might work with that group, or cultural brokers, cultural consultation would really, really be helpful in ensuring, and also making sure that this doesn't impact their journey, because the implications for international students are often that they lose like their visa, they have to maintain a certain course load. So really working with the educational institution in a way that they understand that this might be impacting and that there needs to be some flexibility with respect to coursework and other things. So the cultural piece and the working and liaising with the educational institutions is super critical.
Thank you.
Thank you very much. I think our time is just almost up there, although we could probably chat for another couple of hours. Dr. Iyer, thank you so much. That's been incredible and actually has just got my brain churning about these take-home messages that you've given us to really think about here in Scotland, and how we think about how we can guide other boards in that rural aspect, and the different models that you've used in accordance to geographical context, but also I guess resource and what's already functioning in an area.
Absolutely.
And to not try and make something fit that isn't going to in that specific area. So there's a lot for us to think about. So that was incredibly helpful, and thank you so much for that. I just wanted to finish up also by just, for the audience who are listening, just to say you can follow us on Twitter, on email, you can contact us and visit our website. We've got lots of resources and things on there, and we'll be keeping you updated with how the programme is going currently with what we've got. We'd also really appreciate any feedback. So we have got an evaluation form going into the chat box in the wee second. And as part of our ongoing series, we do have another webinar on the 29th of March in the morning. I think it's going to start about 10:30. And we'll be taking a kind of a youth approach to this one. And we also have Alistair Cook from Scottish Government coming to give us his thoughts on the year ahead for the EIP programme. So it'd be great to see you all there. And finally, just thank you again, Dr. Iyer. That was absolutely incredible. And thanks to the team behind the scenes for making this work. And thanks everybody for joining and for listening in and for all your questions today.
Thank you to the audience. Thank you, Ashley. Thank you, Susie, for facilitating this so well. And thank you so much to the team. It's been, like I said, perhaps the smoothest run webinar I've ever done since the pandemic. And I've done quite a few of those. So this was really good. And I'm hoping that this can be part of an ongoing conversation between us and what you're doing in Scotland, because I think that there's a lot to learn from this sort of exchange.
Well, we have so much to learn from you. Your expertise has been really influential today. So thank you so much. And we'll make sure that you're added to our network and our list for events. So if there's ever any events that you might like to join, we'd be delighted to hear from you. And thank you so much for sharing your knowledge.
Yeah.
It's been great to meet you.
Yeah.
Bye.
Bye-bye.
Thank you very much. Bye.
Bye.